Good day everyone, I am Simon P. Bacala of Group 4 and together with my group mates, we will be discussing about the special diets for children with special needs, specifically autism spectrum disorder, ADHD, cerebral palsy, and G6PD. Now, let us first discuss about autism spectrum disorder. As an overview, autism spectrum disorder is a neurological disorder that affects how people interact with others, communicate, learn, and behave. Although autism can be diagnosed at any age, it is described as a developmental disorder because symptoms generally appear in the first 2 years of life, as per the National Institute of Mental Health in 2024. According to the American Psychiatric Association in 2022, diagnosing autism spectrum disorder necessitates the identification of specific behaviors. The common signs and symptoms include a lack of social interest or atypical social interactions, unconventional play habits, unusual communication behavior patterns, and rigid adherence to routines along with repetitive behaviors. However, since symptoms can evolve with development and may be concealed by compensatory strategies, the diagnostic criteria can be satisfied based on historical information, although the current presentation must result in significant impairment. As reported by the Centers for Disease Control and Prevention in 2025, several distinct factors have been identified that may increase a child's risk of developing ASD, mainly the environment and genetic factors. This includes having a sibling with ASD, having specific genetic or chromosomal abnormalities such Fragile X syndrome or tuberous sclerosis, having problems at birth, and being born to elderly parents. For the nutrition-related pathophysiology, we have identified the risk factors, which are genetics and environment, as the main etiology why autism spectrum disorder develops. According to Sandin et al. 2017 and Tick et al. 2016, genetic factors play a substantial role, with heritability estimates ranging from 64% to 91% and numerous genes associated with synaptic function, neuronal communication, and brain development implicated in ASD susceptibility. Additionally, environmental factors such as advanced prenatal age, prenatal exposure to valproate, maternal infections, and complications during pregnancy or birth have been linked to an increased risk of ASD because it has been shown that it disrupts neurodevelopment through mechanisms including oxidative stress, mitochondrial dysfunction, and epigenetic changes, as per Rosignol and Fry 2012 and Mudabernia et al. 2017 and Lyell et al. 2017. The rare genetic mutations, such as single-gene disorders, copy number variations, and single nucleotide polymorphisms, can impair biochemical pathways critical for brain development and function, according to Sandin et al. 2014. For example, metabolic disorders like branched-chain ketoacid dehydrogenase kinase deficiency and phenylketonuria hinder amino acid metabolism and transport, which are both crucial for the production of neurotransmitters and the functioning of neurons, according to Zygmunt et al. 2021. Alterations in the SLC7A5 gene, which are responsible for encoding a transporter for branched-chain amino acids, result in a lack of amino acids in neurons, compelling them to depend on less effective lipid metabolism, which ultimately leads to neuronal death and symptoms resembling autism, as per Gaziodin and Al-Owain 2013. A nutrient-poor diet characterized by high carbohydrate content can worsen nutrient metabolism and immune dysfunction in individuals with autism. Children with autism often demonstrate gastrointestinal issues including compromised gut barrier integrity, diminished digestive enzyme production, and ongoing inflammation, which are aggravated by diets deficient in essential nutrients, according to Birding and Donovan 2018. High carbohydrate diets can lead to microbial dysbiosis, elevating levels of proteolytic bacteria that generate toxic metabolites like ammonia and phenols, further harming gut health and intensifying autistic symptoms. Furthermore, a low intake of nutrient leads to decreased levels of vital micronutrients such as omega-3 fatty acids, zinc, and vitamin A and D, which adversely affects immune function and heightens the risk of inflammation, as per Sivamaruti et al. 2020. So, as a result of these disrupted physiological processes, affected individuals may exhibit a wide array of clinical presentations such as repetitive behaviors, attention deficits, sensory disorders, social dysfunction, sleep disturbances, and a restricted range of the interest. These symptoms are consistent with the diagnostic criteria for spectrum disorder as they reflect the underlying neurological and the biochemical dysfunctions stemming from the earlier risk factors and metabolic impairments of ASD as per the National Institute of Mental Health. There are specific tests to diagnose children with ASD. The primary instrument utilized for diagnosing autism spectrum disorder are the Diagnostic and Statistical Manual of Mental Disorders 5 and Modified Checklist for Autism in Toddlers, which identify ongoing difficulties in social interaction and communication, as well as it assesses answers to yes or no questions across various developmental domains to establish a diagnosis as per Lorda et al. 2021. Now let us first discuss about the DSM-5. The DSM-5, which was created by the American Psychiatric Association and is extensively used by healthcare professionals, specifies two principal criteria for diagnosing autism. Mainly, first, we have the persistent challenges in social interactions and communication, and second is the restricted, repetitive behaviors, interests, or activities, as per the Autism Research Institute in 2024. Furthermore, the DSM-5 comprises three main elements, which are diagnostic classification, sets of diagnostic criteria, and descriptive text. The diagnostic classification contains the official catalog of recognized mental health disorders, each linked with a specific diagnostic code. These codes align with the ICD-10-CM system employed in the U.S. healthcare environments, which are utilized for documentation and billing purposes. For each disorder, the criteria specify particular symptoms that must be present for a designated duration, along with other factors that must be ruled out to confirm the diagnosis. Now, as for the MCHAT or Modified Checklist for Autism in Toddlers, it is a specific screening tool designed for autism spectrum disorder. It is one of the assessments recommended by the American Academy of Pediatrics for use with all children during their 18 or 24-month well-child visits. Alongside the MCHAT, there is a follow-up interview that complements the MCHAT, aimed at further investigating responses to MCHAT questions that may suggest ASD. The follow-up interview was developed due to significant number of false positives associated with the MCHAT, as per the Children's Hospital of Philadelphia Research Institute in 2022. Flashed on the screen is an example of the MCHAT questionnaire. So the scoring algorithm for MCHAT is or most item, yes is a low likelihood response or 0 points, and no indicates an elevated likelihood response or 1 point. However, it is important to note that items 2, 5, and 12 are reversed scored, meaning that no is a likelihood response or 0 points, and yes indicates an elevated likelihood or 1 point. To score the MCHAT, you just need to add up the number of elevated likelihood responses in all of the questionnaires. So this is how MCHAT score interpretation and what are the next steps. For less than 3, no follow-up needed unless surveillance or other procedures suggest elevated likelihood of autism. For a total of 3 to 7, administer MCHAT follow-up. Total score of 2 plus and follow-up, refer for diagnostic evaluation and early intervention. And lastly, for a total of greater than or equal to 8, bypass follow-up, which refer immediately for evaluation and intervention.
Thank you, Mr. Bacala. Now, continuing from where you left off, let's move on to the classification of the autism spectrum as outlined by the American Psychiatric Association in 2022. To start, First is the high functioning autism, or HFA. While it's not normally recognized as a diagnosis in DSM, it is often used to describe individuals who meet the criteria for ASD, but without intellectual disability that is commonly associated with autism. The Giambattista and colleagues emphasized this in 2018. Next, we have autistic disorder, which is also called classic autism. This was once considered a separate diagnosis before the DSM-5. Individuals with classic autism usually present more pronounced symptoms like significant communication challenges and intellectual disabilities. This is what many people traditionally associate with autism. Then there's Asperger's disorder. Asperger's syndrome is still part of the autism spectrum and is characterized by challenges in social interaction and restricted or repetitive behaviors. But unlike classic autism, people with Asperger's usually have average or even above average intelligence. They don't typically experience significant delays in language, although their speech might seem unusual, and they often develop deep, focused interest in very specific topics. Another formal classification is pervasive developmental disorder. This was used for individuals who showed some but not all symptoms of autism. Today, under the DSM-5, they would now be diagnosed as having ASD, and this change helps reflect the idea of autism as a spectrum. And that's really the key takeaway here. The spectrum. It highlights just how broad and diverse autism really is. People with ASD may face a wide range of challenges, but also have different strengths. No two individuals with autism are exactly alike, and recognizing that helps us better understand and support them. Now, let's discuss common tools to assess the nutritional status of children with autism spectrum disorder. Children with ASD often face a range of nutritional challenges. These stem from food selectivity, sensory sensitivities, and repetitive mealtime behaviors, all of which put them at risk for malnutrition. Now let's begin with the first method, the anthropometric measurements. This is one of the most common and non-invasive ways to assess nutritional status. It includes standard measurements like weight, height, and BMI for age, as well as z-scores or percentiles. For instance, BMI for age percentiles help determine if a child is underweight, at a healthy weight, overweight, or obese. According to Mary Bossett and colleagues, 20% of children with ASD fall below the 50 BMI percentile, compared to just about 90% of typically developing peers. At the same time, other studies have also shown a higher prevalence of obesity among children with ASD, which highlights the need for regular and longitudinal monitoring. In addition to basic measures, tools like waist circumference and body composition assessments offer deeper insights into possible metabolic risk linked to unusual eating patterns in this group, as Sharp et al. Pointed out in 2013. Now let's move on to the biochemical measurements. This method is used to assess nutrient levels, especially key micronutrients like vitamin D, B6, B12, iron, and zinc, which are vital for proper growth and development. Because of restricted diets and possible gut issues, children with ASD often face deficiencies. For example, limited dairy intake in this population has been linked to low calcium and vitamin D levels. Blood markers like serum ferritin and hemoglobin are also checked to identify conditions like iron deficiency anemia, which is a common among them. Several studies, including those by Zhu et al. And Stewart et al., report that children with ASD typically show lower serum levels of nutrients like folate, vitamin B12, vitamin D, zinc, and iron. One study even found that ASD children in Chongqing had significantly low ferritin and vitamin A levels than those from Hainan. However, despite the objectivity of this test, biochemical assessments do have challenges. These include difficulty getting children to comply with blood draws and the fact that nutrient levels can fluctuate over time, something Hyman and colleagues emphasized in 2012. Now, now let's move on to another important part of assessing the nutritional status of children with autism spectrum disorder, and that is the use of dietary assessment tools. Starting with the 24-hour food record. This tool gives us a close-up view of what a child eats in a single day. A recent scoping review by Compan Gaubusho and colleagues in 2013 pointed out that 24-hour recalls are among the most frequently used methods to diet for a diet assessment in children with ASD. They're especially useful in identifying patterns like a high preference for processed foods and low intake of fruits and vegetables. Next, we have the FFQs or Food Frequency Questionnaire. Unlike the 24-hour food record, FFQs look at a child's habitual intake over time, making them helpful in identifying repetitive eating patterns, which are quite common in ASD. A study by Zhu and colleagues in 2020 compared ASD children in Chongqing and Hainan, China. They found that FQs help reveal a lower intake of whole grains, dairy, vegetables, and fruits in ASD groups compared to their neurotypical peers. However, it's important to note that the accuracy of both tools depend largely on parental reporting. And as Sharp et al. Pointed out in 2013, this can introduce bias, especially when the child's food choices are very specific or unpredictable. Now let's take a look at behavioral and ASD specific tools used to assess mealtime behaviors in children with autism spectrum disorder. One of the most commonly used tools is the Behavioral Pediatric Feeding Assessment Scale or BPFAS. As shown in the image, it is a parent report questionnaire designed to evaluate children's eating behaviors and parental concerns during mealtime. It includes 19 items that cover a range of feeding behaviors such as willingness to try new foods, problems with chewing, and mealtime tantrums. Parents rate how often each behavior occurs on a scale from never to always and indicate whether each behavior is a problem for them. This tool is especially useful for identifying feeding issues with common in children with autism spectrum disorder, such as food selectivity based on texture or color. However, because it relies on caregiver recall, results may be influenced by parental stress or perception. Another one is the brief assessment of mealtime behaviors in children. The BIMBI and its revised version are tools used to assess eating behaviors, particularly in children and adolescents with ASD. Both versions yield similar scores, including a total score and subscale scores. And the primary distinction is that the revised version can be administered by teachers in a school setting, while it has been used less frequently. One study evaluated its effectiveness in a multidisciplinary intervention for food selectivity in children with ASD. The image shows a part of the BAMBI version questionnaire. It contains 8 questions, and caregivers must answer them based on the frequency of the behaviors during mealtime. Now, let's move on to the specific dietary requirements for children with ASD. The GFC of diet is one of the most commonly implemented dietary interventions involving the removal of gluten and casein proteins from a child's regular diet. This diet was first suggested in the 1980s with the idea that gluten and casein might contribute to autism-like symptoms by affecting brain functions. Support for the GFCF diet's physiological benefits come from studies showing high antibodies or reactions to milk, gluten, and casein. These reactions have been linked to the formation of autoantibodies or pro-inflammatory cytokines. Research has shown that children with ASD who follow the GFCF diet produce less tumor necrosis factor alpha than those who do not follow the diet. Now for the essential macronutrients. First, let's talk about the fiber. Many children with ASD struggle with insufficient fiber intake due to selective eating habits, particularly avoiding fruits, vegetables, and whole grains. This contributes to constipation, a common gastrointestinal issue. Increasing fiber intake through pureed vegetables, fiber fortified foods, or supervised supplements can improve gut motility and microbiome health. Omega 3 fatty acids, particularly the DHA and EPA, are vital for brain development and reducing neuroinflammation. Children with ASD often have lower omega 3 levels, which correlate with behavioral challenges. Supplementation has been shown to improve hyperactivity and social responsiveness, though the results are not consistent across all studies. Dietary sources such as fatty, fish, or flax seeds or high quality supplements are recommended. Next is the protein. Selective eating behaviors can lead to limited protein intake, especially if children reject meat, eggs, or legumes. Insufficient protein can impair growth and neurotransmitter synthesis. Alternative protein sources like plant based proteins can help meet the protein needs of children with ASD. Now, for the essential micronutrients. Many children with ASD avoid dairy products, especially those on GFCF diets, which increases the risk of calcium and vitamin D deficiencies. These nutrients are critical for bone health. Over 50% of children with ASD have insufficient vitamin D, which is linked to immune dysregulation and behavioral symptoms. Fortified plant based milks, supplements, and sunlight exposure can help address these deficiencies. Iron deficiency, which affects 50 to 30% of children with ASD, can lead to fatigue, poor cognition, and restless behavior. Heme iron from meat is more easily absorbed, but non-heme iron sources like lentils and spinach, paired with vitamin D, can improve absorption. Zinc supports immune function and neurotransmitters activity, while magnesium helps calm the nervous system. Study shows that children with ASD often have lower zinc levels, which may worsen sensory sensitivities. Magnesium-rich foods such as nuts and seeds and supplements may reduce irritability. Now for the last essential micronutrients. B vitamins are essential for methylation processes and neurotransmitter synthesis. Many children with ASD have genetic polymorphism that impair folate metabolism. In these cases, active forms of folate or methylfolate and B12 or methylcobalamin are often recommended to address deficiencies. And this concludes our discussion on the nutritional aspects of autism spectrum disorder.
So, good morning, everyone. Today I will be discussing attention deficit hyperactivity disorder, or ADHD. This is a psychiatric disorder that mostly affects children and can greatly impact how they function in life. So, first is our overview. Now, the symptoms usually appear early in development. These include difficulty focusing, being disorganized, forgetting things, losing items, and not finishing tasks. Now, people with ADHD often have higher than normal levels of impulsivity, hyperactivity, or inattention for their age. Now, to meet the criteria for the diagnosis, the symptoms must begin before the age of 12. So it should last for at least 6 months and cause significant problems in daily activities such as the school, home, or social life. So, as you can see here, from a neurological perspective, ADHD is linked to underactivity in specific brain areas, particularly the frontal, striatal, and cerebral circuits, which are areas that are important for executive functions, like focusing attention, planning, controlling impulses. So what happens is that when these brain circuits don't function well, it will become harder for individuals with ADHD to stay organized, manage your behavior, and complete tasks properly. So now ADHD is also influenced by a variety of genes, inheritable variables and their interactions, just like other common medical illnesses such as medical and mental illness such as schizophrenia and asthma. Now there is no single cause of ADHD, see, and exposure to risk factors do not necessarily result in disorder. So now, knowing that environmental toxins or psychological trauma are also two examples of how genes might change sensitivity to environmental dangers, such as gene environment interaction. In addition to ADHD, a variety of neurodevelopmental and neuropsychiatric outcomes come to be linked to the genetic and environmental risk factors that have been implicated. So, according to Thapar et al. 2011, according to his available data, ADHD is most likely caused by a combination of rare and numerous common genetic variations that alter its phenotype. So this is what I have said earlier. No, the symptoms. No, rather, this is the diagnosis or the criteria for diagnosis, in which the symptoms must begin before the age of 12, which should last at least 6 months, and it should cause significant problems in daily activities such as school, home, or social life. Now, moving on is the nutrition-related pathophysiology. So, attention deficit or ADHD is a complex neurodevelopmental condition which affects mainly 3 to 7% of school-age children, according to Polanzik et al. 2007. Now, as I mentioned earlier, it is not caused by a single factor, but rather by the interaction of multiple genetic and neurological factors that work together to shape the brain's development and function. But according to Aguiar et al., genetically, ADHD is highly heritable, with approximately 76% symptoms variation being linked to inherited traits. Now, these genetic factors often include polymorphisms in the dopamine transporter gene, or DAT1, and dopamine receptor genes, DRD4 and DRD5, which affects the brain's ability to regulate dopamine and norepinephrine, which are two critical neurotransmitters responsible for attention, motivation, and self-regulation. So these genetic vulnerabilities impacts the brain structure and function, particularly the prefrontal cortex and the basal ganglia. So these brain structures are essential for controlling the attention, the behavior, and emotional regulation. So the PFC dysfunction, or the prefrontal cortex dysfunction, interferes with the person's ability to stay focused or suppress impulses. So in a deep sense, the right hemisphere of the prefrontal cortex especially plays a dominant role in regulating attention and behavior, while the dorsolateral part helps manage motor responses and attention, and the medial parts handle emotions, according to Arnson 2009. So another thing is that deformations in the basal ganglia, which is often seen in people or children with ADHD, reduces their ability to filter out distractions and control impulses. Now, these these neurological abnormalities with genetic abnormalities directly causes the core of ADHD symptoms, your inattention, impulsivity, hyperactivity, and executive dysfunction. Now, these symptoms then contribute to secondary behavioral and physiological issues. For instance, impulsivity and poor executive function makes it difficult to stick to regular meal schedules or make healthy food choices. As a result, the individuals may develop disordered eating behaviors such as skipping meals, binge eating, or craving high sugar and high fat foods. Now, additionally, many individuals with ADHD are treated with stimulant medications that, while although helpful for attention, it often suppresses appetite, which then leads to further reduced food intake, especially among children and adults. So now over time, these eating patterns and medication effects will now cause nutritional problems. So reduced intake and poor eating habits results in micronutrient deficiencies or poor dietary quality. So now when people aren't eating enough or are eating poorly, they often lack essential nutrients such as iron, which is critical for dopamine synthesis. And without enough iron, basically dopamine production also slows down, worsening symptoms like inattentiveness and hyperactivity. Similarly to that, zinc and magnesium are also both essential for neurotransmitter regulation and nerve function. So, therefore, which may become deficient, leading to further disruptions in the brain. Another thing is that omega-3 fatty acids, which is important for the neuron membrane function, are often lacking as well, which negatively affects in cognitive performance as well as the behavior. Now, coupled another the second thing is that poor diet quality, especially from processed foods high in sugar and fat and low in fiber and antioxidants, which can trigger oxidative stress and inflammation in the brain. Now, these foods, not only is that they are not nutrient dense, they also promote damage by increasing the number of free radicals on the body. Now, then, coupled with his inadequate antioxidant intakes or healthy intakes, the body cannot counteract this without antioxidants. So, oxidative stress builds up, damages brain cells, particularly in already vulnerable areas like the prefrontal cortex or and the basal ganglia, which then leads to further neurotransmitter imbalance, which is worsened by behavioral regulation and more severe symptoms of ADHD. So, genetic and neurological factors set the stage for these ADHD symptoms. Here. Oh, rather, sorry. Combined with the medication side, these symptoms, then combined with medication side effects, contribute to the poor appetite and disordered eating, which then leads to nutritional problems, in which nutritional deficiencies and poor quality diets then worsens the brain function and the activity of neurotransmitters, making a vicious cycle of where the symptoms of ADHD are both the cause and consequences of poor nutrition and brain chemistry imbalance. So moving on is how do we classify ADHD based on spectrums? So when diagnosing ADHD, the first step is to evaluate the core symptoms: inattention or hyperactivity, impulsivity. So as I said earlier, the symptoms must last for at least 6 months, appear before the age of 12, and cause different problems in different areas of life: schoolwork, social situations. So now, according to the American Psychiatry 2022, or rather, according to the American Psychiatry Association, so they use a tool called the Diagnostic and Statistical Manual of Mental Disorder, the 5th edition text revisions, or DSM-5-TR, which outlines 3 types or presentations of ADHD. First is the predominantly inattentive presentation with a code of F90.0. This is when the person struggles with paying attention, organizing tasks, or often seems forgetful and distracted. Now, next is the F90.1, which is the predominantly hyperactive impulsive presentation. Now, this is marked by restlessness, fidgeting, excessive talking, or acting without thinking. The next is combined presentations, which is F90.2. This is when both are the inattentive and hyperactive impulsive symptoms are equally noticeable, or they are rather combined, easily spotted on in one person. Rather, both F90 and F90.1 is present in a person. Now, each presentation reflects different brain activities. No, so according to Ferrone et al. 2015, neuroimaging studies show that people with hyperactive impulsive types may have changes in the striatal regions of the brain, while those with the inattentive type may show lower activity in the prefrontal cortex. Now, next is identifying or classifying rather ADHD based on the severity of the symptoms. First is mild, where symptoms cause only minor problems. Next is moderate, in which is the borderline for mild and severe, while severe is for symptoms leading to difficulties in daily life. Now, so how do professionals measure this? They often use tools like the ADHD rating scale 5, which help tracks and how often symptoms occur and how much they affect a person's ability to function. So it is also important to consider comorbidities. Comorbidities meaning other conditions that often occur with ADHD, such as anxiety, learning disabilities, or mood disorders, which can affect how symptoms appear and how they should be treated. So, in adults, symptoms may change over time and not meet the full criteria, but executive dysfunction like poor time management or planning may still be present. So, another thing is that it is worth noting that cultural context matters. In some settings, behaviors like hyperactivity may be viewed differently, which means clinicians must be careful to avoid misdiagnosis based on the cultural norms of a person.
Diagnosing ADHD in children requires a comprehensive and systematic approach. Clinicians primarily rely on the criteria outlined in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revised, or DSM-5TR, published by the American Psychiatric Association in 2022. According to the DSM-5TR, ADHD is characterized by a persistent pattern of inattention and/or hyperactivity impulsivity that interferes with functioning or development. To meet diagnostic criteria, a child under the age of 17 must display at least 6 symptoms from either the inattentive or hyperactive impulsive category. Importantly, these symptoms must be present for a minimum of 6 months and must be inconsistent with the child's developmental level. The DSM-5-DR requires that several symptoms must have been evident before the age of 12 and that they must occur in at least two different settings, such as at home and at school. There must also be clear evidence that these symptoms negatively impact social, academic, or occupational performance. Additionally, these symptoms must not be better explained by another mental health condition such as anxiety, depression, or a psychotic disorder. Based on symptom patterns, ADHD is classified into three subtypes: the predominantly inattentive presentation, the predominantly hyperactive impulsive presentation, and the combined presentation where the both sets of symptoms are equally evident. Clinicians must also determine the severity of the disorder, which are mild, moderate, or severe, depending on how much the symptoms interfere with daily functioning. In some cases, partial remission may be specified when the full diagnostic criteria were previously met but fewer symptoms are now present, although some impairment still exists. In practice, Diagnosis involves a multimodal assessment process that includes clinical interviews, behavioral observations, standardized questionnaires for both parents and teachers, and a thorough developmental and medical history. This ensures that ADHD is diagnosed with accuracy and that interventions can be tailored effectively. In addition to clinical interviews and observations, the diagnosis of ADHD in children relies heavily on structured behavioral rating scales, which help operationalize the DSM-5-TR criteria. One of the most widely used and scientifically validated tools is the ADHD RS5 or ADHD Rating Scale 5. This scale consists of 18 items directly aligned with the DSM-5-TR symptom criteria, divided evenly between inattention and hyperactivity impulsivity. Respondents, which are usually parents or teachers, are asked to rate each behavior based on how often it occurs in the child's daily life, using a 4-point scale from 0, which is never, to 3, which is very often. Behaviors assessed include examples like difficulty sustaining attention or excessive fidgeting. What makes this skill particularly useful is its ability to both quantify the severity of symptoms and differentiate between ADHD subtypes. For instance, if a child scores 6 or more symptoms in the inattentive category, they may meet the threshold for the predominantly inattentive presentation. The same applies for the hyperactive impulsive category. However, if both thresholds are met, the child may be diagnosed with combined presentation. Research shows that ADHD RS5 has excellent reliability with internal consistency values measured using Cronbach's alpha, which is consistently above 0.85. It's also been proven to be sensitive to treatment effects, making it not only valuable during diagnosis, but also effective for tracking symptom changes over time. While the ADHD RS5 is a leading tool, it's important to note that clinicians rarely rely on a single data source. A core principle in ADHD assessment is gathering multi source information, typically from both parents and teachers. This provides a more holistic view of a child's behavior across settings, which is essential since ADHD symptoms must be present in at least two different environments. As shown from this scale, respondents rate behaviors like quote unquote has trouble organizing tasks and activities using this frequency scale. This approach not only standardizes symptom evaluation but also helps in identifying patterns that might not be immediately visible in a single setting. Ultimately, behavioral rating scales like these ADHD RS5 serve as a structured, evidence based method to support diagnosis, guide subtype classification, and monitor the effectiveness of interventions over time. Another widely used tool in the assessment of ADHD is the Vanderbilt Assessment Scales, developed for use in both clinical and primary care settings. These skills are completed by parents and teachers, and they go beyond symptom checklists by also evaluating the functional impact of behaviors and the presence of possible comorbid conditions. This skill includes 55 items divided into two main sections. Part 1 focuses on the core ADHD symptoms aligned with the DSM-5-TR, and Part 2 screens for co-occurring issues like oppositional defiant disorder, anxiety and depression, as well as academic and social performance challenges. To meet diagnostic criteria using the Vanderbilt, a child must exhibit 6 or more symptoms in either the inattentive or hyperactive impulsive domain. But unlike some other tools, the Vanderbilt also requires evidence of functional impairment, particularly in school or social settings. This dual focus on symptoms and their real-world impact makes the scale a more holistic diagnostic instrument. Research supports its accuracy and efficiency. A study by Bart et al. In 2013 reported that the Vanderbilt demonstrated 94% specificity in distinguishing ADHD from other behavioral disorders, especially valuable in busy primary care environments where differential diagnosis is critical. As seen here in the sample first page, each behavior is rated by frequency, and impairment levels are also documented. This structured approach allows for both thorough screening and ongoing monitoring of treatment effectiveness. Overall, the Vanderbilt scales are a practical, validated, and multidimensional tool for identifying ADHD and associated concerns in real world clinical settings. In diagnosing ADHD, it's crucial that symptoms are not only present but also persistent, developmentally inappropriate, and observable across multiple settings. This cross situational requirement helps distinguish ADHD from more transient or situational behaviors. Rating scales like the Vanderbilt scales in the ADHD RS5 are specifically designed to reflect this DSM-5-TR criteria. For example, the Vanderbilt's inclusion of academic performance helps rule out symptoms that might otherwise be explained by intellectual disabilities. While these tools are central to diagnosis, they are not used in isolations. Clinicians may order neuropsychological testing to identify coexisting conditions like dyslexia, but this test alone cannot diagnose ADHD. Similarly, physical exams, including thyroid function tests, are often conducted to exclude medical conditions that can mimic ADHD symptoms. Clinicians also take detailed developmental histories to confirm that symptoms were present before age 12, as required by the DSM-5-TR. Additionally, clinical interviews help rule out other causes such as anxiety, trauma, or sleep issues. Ultimately, accurate diagnosis depends on integrating multi-informant reports, clinical judgment, and longitudinal observation, which not only improves diagnostic precision but also helps avoid overdiagnosis, especially in young children where impulsive behavior may still fall within the range of the normal development. Assessing the nutritional status of children with ADHD is essential due to their unique interplay between their neurodevelopmental condition and eating behaviors. Children with ADHD often face challenges like erratic eating patterns, selective food preferences, and appetite suppression from stimulant medications, which can result in micronutrient deficiencies and altered growth trajectories. One of the primary tools used in both clinical and research settings is anthropometric measurement, including height, weight, and BMI. These indicators allow clinicians to evaluate growth patterns against standardized age and sex specific charts. They are especially valuable in children with ADHD who may experience either growth delays, especially when on stimulant medications, or increased risks of overweight and obesity, depending on lifestyle and behavioral factors. Because anthropometric data are non-invasive and cost-effective, they are widely used to screen for potential nutritional risks. Studies, such as those by Patelsik et al. In 2014, highlight how BMI fluctuations in this population are often linked to the behavioral characteristics of ADHD, as well as the appetite-suppressing effects of medications. Routine monitoring of these metrics is therefore recommended to ensure nutritional adequacy and to inform necessary treatment adjustments. While research suggests some biochemical differences in children with ADHD, it's important to note that these differences are not always consistent or specific to the disorder. Still, biochemical measurements can offer valuable insights into nutritional status that may influence symptom severity and treatment outcomes. One of the most studied nutrients is zinc. Up to 66% of children with ADHD have been found to have suboptimal zinc levels. Since zinc supports dopamine regulation and neurotransmitter function, supplementation has been shown to reduce symptom severity in zinc deficient individuals. Furthermore, iron levels measured through serum ferritin are also a focus. Low iron has been linked to increased hyperactivity and inattention. There's also growing interest in copper zinc imbalances, particularly elevated copper zinc ratios, which may contribute to behavioral issues, though the evidence here is still mixed. Beyond minerals, fatty acid profiles and vitamin levels are commonly assessed. ADHD is often associated with low omega 3 levels and an imbalanced omega 6 to omega 3 ratio, which can affect cognitive function. Deficiencies in B vitamins and vitamin D are also common and may exacerbate neurotransmitter issues and neurocognitive deficits. However, because of variability in individual factors like diet, genetics, and study design, these biochemical results should always be interpreted in context which is integrated with clinical observations and dietary data to inform a personalized care plan. Dietary assessment tools are critical in understanding the nutritional patterns and deficiencies often seen in children with ADHD. These children frequently show erratic eating patterns and a preference for low nutrient, high sugar foods, which can worsen their symptoms. Two commonly used tools in both clinical and research settings are the 3-day food record and the 24-hour food recall. These help quantify short-term intake of nutrients. For example, one pilot study found that 66% of children with ADHD had suboptimal zinc intake, a nutrient tied to attention and behavior regulation. To assess long-term habits, clinicians often use food frequency questionnaires or FFQs. These tools have shown that children with ADHD typically consume more simple sugars and fewer vegetables, proteins, and essential vitamins like B1, B2, and zinc compared to neurotypical peers. Another tool, the oligoantigenic diet, also known as an elimination diet, is used to identify food sensitivities that may trigger or worsen symptoms. This approach removes common allergens like gluten, dairy, and food additives and gradually reintroduces them while tracking behavior. In one major trial, children showed significant improvements in hyperactivity and inattention during the elimination foods. However, this diet is restrictive and is not suitable for everyone. These tools, like the FFQs, food records, and elimination diets, are often used together as a part of the multidisciplinary approach, and longitudinal studies have found that diets high in saturated fat and low in omega 3s are linked to persistent ADHD symptoms, while diets rich in vegetables, proteins, and micronutrients correlate with improvement. Ultimately, no single tool gives the full picture, but combining methods allows for personalized dietary strategies that evolve with the child's needs, supporting better long-term management for ADHD. Children with ADHD often face unique nutritional challenges that can aggravate their symptoms. These challenges include erratic eating patterns and micronutrient deficiencies, which can contribute to heightened hyperactivity, inattention, and behavioral issues. Structured dietary interventions, such as eliminating artificial additives, gluten, or dairy, have shown promise in reducing symptom severity for some children. For example, a randomized controlled trial found that an oligoantigenic diet, which eliminates common allergens, led to significant behavioral improvements. However, sticking to this restrictive diet in the long term remains difficult for many families. Micronutrient supplementation, especially of zinc and iron, is another avenue that may help. Deficiencies in these nutrients can impair dopamine synthesis, which is crucial for attention and behavior regulation in children with ADHD. Supplementation can be beneficial, but it should only be done after confirming deficiencies to avoid potential side effects. This highlights the importance of individualized nutritional guidance. In addition to targeted supplements, research supports whole food, nutrient dense diets like the Mediterranean diet, which is rich in fruits, vegetables, whole grains, and omega 3 fatty acids from sources like fatty fish. These diets are associated with reduced ADHD symptoms, likely due to their anti inflammatory properties and their support of neurotransmitter function. On the other hand, high consumption of processed foods, refined sugars, and saturated fats may worsen ADHD symptoms due to their impact on gut microbiota and systemic inflammation. Omega 3 fatty acids, particularly EPA and DHA, play a key role in neural health. Meta analyses show modest but significant improvements in hyperactivity and impulsivity when children with ADHD supplement with omega 3s. There's also growing evidence suggesting that gut brain interactions may contribute to ADHD symptoms, with probiotics and fiber rich diets showing promise in reducing ADHD related gut dysbiosis. However, further research is still needed. Practical dietary management for children with ADHD also needs to consider the impact of medication, particularly stimulants, which can suppress appetite during the day. This increases the risk of nutrient gaps and compensatory overeating later in the day. To manage this, strategies like nutrient dense breakfasts, protein rich snacks, and consistent meal schedules can help stabilize energy intake and prevent deficiencies. Lastly, it's important that any dietary approach is part of the collaborative effort with healthcare providers. This ensures that interventions are tailored to each child's unique needs, supporting both their developmental needs and treatment plans. While dietary changes alone are not a cure for ADHD, they can serve as an important complementary tool to pharmacotherapy and behavioral interventions, helping to provide a more holistic approach to managing ADHD symptoms.
Next is cerebral palsy. What is cerebral palsy? Cerebral palsy, or CP, is a neurodevelopment disorder caused by a permanent, non-progressive brain injury during early brain development. Most of the cases for the children happens below 2 years old, where their brain is not yet fully developed, and then this condition is stagnant, which means it's not progressing as they grow older. It affects muscle tone, movement, and motor coordination. CP occurs in 2 to 3 per 1,000 live births, with approximately 92% linked to perinatal events. Major risk factors of CP are premature birth, perinatal infections, or the chorioamnionitis, which is the infection of the chorion, amnion, and the amniotic fluid. Next is the intrapartum hypoxia, and most cases are, and the causes of it are not identified, which is tagged as idiopathic, and it holds around approximately 80% of the total cases. CP is categorized according to motor impairments, and it is either spastic, which holds approximately 80% of the total cases, which is it's the most common type of CP, then dyskinetic, ataxic, or mixed types of this. Next, secondary issues include hip dislocation, foot deformities, postural issues, hand function limitations. Associated conditions are cognitive impairments, which most of the children with CP have late cognitive development, epilepsy, and sensory deficits. Next is the nutrition-related pathophysiology. So as what I've mentioned earlier, cases of CP, approximately 80% of it has no known causes. However, some of the recorded causes originates from prenatal, perinatal, and postnatal brain injuries. For prenatal causes, which has 70 to 80%, are the antepartum hemorrhage, maternal infections, or placental insufficiency. But there are still more of it. These are just the common causes. For the perinatal causes, it could be birth asphyxia, prematurity or low birth weight, hypoxic or hypoxic ischemic injury, which all of this could cause to white matter damage of the brain. Next is the postnatal causes. Postnatal causes are either intracerebral hemorrhage, kernicterus, or traumatic brain injury, which happens within the first 2 years of the child, where their brain is still developing. Next, other contributing factors are the genetic abnormalities or maternal conditions, which the mother could be having malnutrition or having thyroid issues. So, this could result to the damage of the neuron motors of the brain, which is now your cerebral palsy. So for your cerebral palsy, this could be categorized as spastic, dyskinetic, or ataxic. What is spastic cerebral palsy? It is the damage to the motor cortex of the brain. This is characterized by stiff, tight muscles. Subtypes of this are hemiplegia, paraplegia, and quadriplegia. So what is hemiplegia? It is when the left or one side of your limbs, either left or right, up and down, of course, is affected, while your paraplegia is both of your lower limbs are affected, while the quadriplegia is up, down, left, and right of your limbs are affected. Next is the dyskinetic CP. It is the damage to basal ganglia, which it causes uncontrollable twisting movements. For ataxic CP, it is the damage to the cerebellum, which could result in poor balance and coordination. Most of the patient with ataxic CP has a problem with their gait. So all of these types involve damage to upper motor neurons. So the neuromuscular manifestation of this is a muscle spasticity, weakness, and hyperreflexia, and involuntary movements such as dystonia or chorea. So since this is what happens in cerebral palsy, it could affect or cause impaired motor skills and muscle spasms. Due to impaired motor skills, a patient could have oropharyngeal dysphagia, which is the difficulty of chewing and swallowing because they cannot control their muscles and they are having involuntary muscle movement. And this could be a risk of aspiration. And because of this, there is a risk of feeding difficulties. The patient is having feeding difficulties because they cannot properly chew their food, thus they are having difficulties of taking in the food. Next, for the muscle spasm, because of the muscle spasm, GERD could happen. This is because due to neuromuscular dysfunction causing vomiting, discomfort, and poor intake, which because the food cannot fully enter the small intestine of the patient where the absorption of nutrients happen, there is nutrient malabsorption. So all of this could result to low nutritional intake, which is an undernutrition risk, and if it prolongs, it could result to undernutrition and malnutrition. There would be low energy intake, increased energy needs due to spasticity, and poor absorption. That's why it could lead to undernutrition and malnutrition. And that is why patients with cerebral palsy needs a multidisciplinary care, because complications are secondary of cerebral palsy, but once it progresses without proper intervention, it is lethal for the patient. Next is the common tools used to assess the nutritional status of children with cerebral palsy. So, nutritional assessment in children with cerebral palsy involves a comprehensive approach due to challenges like feeding issues, irregular growth, and varied energy needs. To ensure accuracy, both general and CP-specific tools are used as recommended by the ESPGHAN, ASPEN, and WHO. So for the anthropometric measure in weight is really difficult or could be challenging to get in children with CP because they could have contractures and posture problems. And also they are having uncontrolled muscle movements. So if ever the child could stand still, we could still use the digital scale available and follow the normal protocol in weight assessment. If there is no digital scale available, two options could be done. First is ask the most recent weight information or consult other health professional. But in this case, we are the health professional in getting this, so we just do it by asking the recent recorded information. Next, if the children can stand still, we could use or weigh them in a wheelchair scale. However, most of some cases, if wheelchair scale is not available, we could weigh them in the arms of a caretaker or the tiered scaling or weighing, or we could get their weight by measuring the new walk and apply the Ruiz-Brunner's equation as recommended by the ESPGHN. So for the Ruiz-Brunner's equation, it is this table above. If the child is within the level 1 to 3 in GMFCS classification, we should use the first equation, which is the 2.52 times mu walk in centimeter plus 1.19 times age in years minus 32.15. However, in some cases of cerebral palsy, if they are in the level for 4 to 5, we should use the 2.02 times mu walk in centimeter plus 0.97 plus age in years minus 22.5. So that is for the weight. And for the height, same with the weight, it's also difficult to get, because as in some cases there are children with cerebral palsy who have scoliosis, kyphosis, or fixed contractures of the lower limbs, and resulting to height may also resulting to height as a difficult to get if we use the common or the common ways of getting it. However, if there are also children with cerebral palsy who can still lay down or stand straight. If they can lay down, we can get their measurement using the supine length, or if they can stand straight, we could get their measurement using the standing height or the regular getting of the height, which this we should follow the normal protocol still. However, if children can't lay down or stand straight due to spasticity, joint contractions, or scoliosis, or as what I've mentioned earlier, the kyphosis, we should use the alternative measurement. What are these measurements? First, we could measure the knee height and follow the equation of Trombley or Stevenson. However, we could also use the tibial length, which we should follow the Stevenson equation or measure the arm length using Stevenson equation, or measure the ulnar length using the Gold equation as recommended by the ESPGHAN. So, for this, in determining what alternative measurement should you do, you just focus on which limb or which part is the least affected. Example, if the patient is affected on the knee or the lower limb, they are having paraplegia, which means you could use the arm length. Just use the least affected part for getting the height of the children with cerebral palsy using the alternative measurement.
Now let's go over some additional tools we use to assess the overall nutritional status of children with cerebral palsy. First, the CP-specific growth chart. Instead of using the regular growth charts like WHO or CDC ones, we now have the CP-specific growth chart that are categorized by GMFCS levels. For example, the Brooks and the day charts. This chart allow us to track growth in children with cerebral palsy within their own functional group, giving a much more accurate picture. The second is the body mass index or the BMI. BMI is still calculated as weight divided by height squared, but for the children with the cerebral palsy, interpretation should be done with caution. It is best to use the CP-specific reference or the C-score rather than standard percentiles. The third one, we have the Subjective Global Nutritional Assessment or the SGNA. This is the semi-structured clinical tools that combines information from child history like the weight change, the food intake, and the GI symptoms with the physical finding like muscle wasting. It's helped classify children as well-nourished, moderately malnourished, or the severely malnourished, making it very useful for clinical decision. And the fourth and the sixth one is the bioelectrical impedance analysis or BIA. It is a non-invasive method for estimating body composition like fat mass and lean body mass. While useful, it should be interpreted carefully in children with the cerebral palsy due to movement limitation. And we have the feeding and swallowing assessment. This is especially important in cerebral palsy. We start with clinical feeding observation but may also use instrumental studies like the video fluoroscopic swallow study or the VFSS or the fiberoptic endoscopic evaluation of swallowing or the FES. These help identify issues like dysphagia, aspiration risk, and inefficient swallowing. And the fifth one, we have the dietary intake assessment. We often use 24-hour recalls, food diaries, or food frequency questionnaire or FFQ to evaluate the nutrient intake. These are then compared with the age-specific RDI to check for the adequacy and help guide dietary changes. And for the last one, we have the biochemical markers. It is a lab tests such as the albumin, pre-albumin, and vitamins and minerals levels can provide helpful insight, but remember, they should never be used in isolation. They work best when combined with anthropometric and clinical assessment. And in summary, assessing the nutritional status in children with the cerebral palsy is complex but essential. We rely on a wide range of tools from anthropometric measurement and growth chart to functional assessment and lab tests. These tools allow healthcare providers to develop personalized, safe, and effective nutritional intervention. By tailoring this assessment to each child's physical condition, mobility, and feeding ability, we can ensure better growth, help prevent malnutrition, and promote overall health, all while aligning with the international best practices from organizations like WHO, the ESPG, HAN, and the ASPEN. And that's all for the additional tools in diagnosing the nutritional status of the cerebral palsy. And that's all for the specific, and that's all for the additional nutritional assessment tools. And that's all for the other nutritional assessment tools. So I'll be discussing the specific tests used to diagnose children with cerebral palsy and how the overall diagnostic process works. To begin with, it is important to understand that there is no single test that can definitively diagnose cerebral palsy. Instead, the diagnosis involves a comprehensive and step-by-step approach combining clinical observation with the specialized tools. Usually, the process starts very early, often during routine well-child visits. At this stage, the physician or the doctor carefully monitor the child's development. They pay close attention to motor skills, muscle tone, posture, coordination, and even the sensory function like vision and hearing. Now, if the doctor notices any delay or abnormalities, that when they begin more detailed assessment. This is where imaging tests comes into play to check for any structural problems in the brain. We have first the MRI or the magnetic resonance imaging. The MRI is considered the gold standard when it comes to imaging for cerebral palsy. Why? Because MRI provide a highly detailed view of the brain tissue, making it easier to spot specific issues like lesion, the white matter damage, or brain malformation. And these are all commonly associated with cerebral palsy. The MRI is especially helpful in diagnosing cerebral palsy in children where there's a history of birth complication or the prematurity, since it gives a clearer pictures of what might have gone wrong during early brain development. And the second, we have the cranial ultrasound. In case where the child is premature, infants, or medically fragile, the doctor may first use a cranial ultrasound, and this imaging test is preferred in this situation because it's non-invasive and safe and can be done right at the bedside. Now, while the cranial ultrasound isn't as detailed as MRI, it is still give valuable initial information, especially about the bleeding in the brain, the fluid buildup, or the sign of brain under development. So think of it as a useful screening tools, especially in NICU settings. And the third, we have the CT scan or the computed tomography. Sometimes if the MRI isn't available or practical, a CT scan may be used as an alternative. Though a CT scan don't provide as much detail as MRI, they can still detect important features like older brain injuries, bleeding, or calcification in brain tissue. These findings can help support a diagnosis of cerebral palsy, especially if the damage occurred around birth or early infancy. Next is the EEG or the electroencephalogram. Another key test is like the EEG, which is typically done when a child is suspected in cerebral palsy, is also showing sign of seizure, which are fairly common in this population. And EEG measures the electrical activity of the brain and help doctor figure out where there are child also has the epilepsy or any other seizure related disorder. It is not used to diagnose the cerebral palsy directly, but it helps to complete the picture. And finally, once the cerebral palsy is diagnosed, it is important to assess how much the conditions affect the child's ability to move. That's where the gross motor function classification system or the GMFCS come in. These tools categorize children into five levels from level 1 to level 5. In level 1 means the child can walk independently with little to no limitations. And level 2 means they can walk but may have troubles with balance or uneven surface. And level 3 involves the use of mobility aid like a walker. And for the level 4 means the child has very limited mobility and may use a powered wheelchairs. And for the last, we have the level 5 refers to the most severe impairments, children who need full-time physical supports. The GMFCS is the most useful for children's aged 6 to 12 and give families and healthcare teams a clearer understanding of what to expect. It has also helped with the setting goals, planning, therapies, and predicting long outcomes. Now let's move on to another very important topic, which is the specific dietary requirement for children with cerebral palsy. So children with the cerebral palsy often face a unique set of nutritional challenges. This can be due to the several reasons such as the feeding difficulties, reduced mobility, muscle tone abnormalities, and sometimes even the nutrient malabsorption. All these factors can lead to inadequate intake and nutritional deficiency if not properly managed. So, what can we do about it? Well, there's where the individualized dietary plannings comes in. Creating a personalized plan is essential to support a child's growth, development, and overall health. And now, let's talk about the energy requirements. This is the one area where the children with the cerebral palsy really vary. So children with high muscle tone and increased activity levels actually burn more energy. So they need more calories to maintain a healthy weight and support growth. On the other hand, the children with low muscle tone or the limited mobility may use up less energy. So giving them too many calories can actually lead to excess weight gain. That's why it's so important to monitor their growth regularly, tracking their weight, height, and body composition. It helps to ensure their energy intake is just right, not too little, but not too much. And now, let's focus on nutrients because some are especially important for children with cerebral palsy. One major concern is the bone health. These children are often at higher risk for low bone mineral density and fracture. To help strengthen their bones, they need adequate amounts of calcium, vitamin D, and phosphorus in their diet, which is the calcium is mainly found in dairy products like milk, cheese, yogurt, as well the fortified juices. And for the vitamin D comes from safe sun exposure, but also from fortified foods such as the cereals and meals. While in phosphorus, it's found in foods like meat, fish, egg, dairy, and whole grains. In addition to those other macronutrients like vitamin C, vitamin K, magnesium, zinc, and copper also play vital roles in bone health and immune function, so they should be included as part of a balanced diet. And now, you might be wondering what's about protein. So interestingly, the protein needs for children with the cerebral palsy is usually not as different from typically developing children. However, there's a catch. The children who are undernourished or not growing properly may need extra protein and calories to support the catch-up growth. So again, this depends on the individual child's condition, and dietary plan should be personalized accordingly. And one of the biggest challenges these children face is the feeding difficulties. These include issues like the oropharyngeal dysphagia or the difficulty swallowing, the delayed swallow reflex, the poor tongue coordination, or an exaggerate bite reflex. And all this can lead to longer meal times, not getting enough food, and in some cases, a serious risk of aspiration pneumonia. To manage this, food texture and fluid consistency may need to be adjusted. A specialized feeding therapy might recommend taking liquid, puree, meals, or small bite-sized portion depending on child ability. They may also suggest a specific feeding position to keep the child safe and reduce the fatigue during mealtimes. And sometimes the oral intake alone just isn't enough. When that happens, the oral supplement like high calorie drinks, protein powder, or fortified food can help to fill in the nutritional gaps. In more severe cases, when oral feeding is unsafe or inefficient, doctors may recommend the enteral feeding, either through a nasogastric tube or the gastrostomy tube. These methods ensure the child receives the nutrients they need consistently and safely. This is especially important when the child has severe dysphagia, is at high risk for aspiration, or take too long to eat. And in the end, every child with cerebral palsy is different. That's why individualized nutrition planning is the key. And the multidisciplinary team, including the doctor, a registered dietitian, and sometimes a speech or the occupational therapist, should work together to develop a plan that meets the child needs in a way that is safe, sustainable, and nutritionally complete. With the right support and careful adjustment to feeding techniques, food textures, and nutrient composition, we can help these children achieve better growth and health outcomes. And it's worth emphasizing that poor growth in children with cerebral palsy is most often due to an insufficient diet. With the right assessment and planning, we can truly make difference. And each case is unique, and that's why personalized care is not just helpful, but it's essential. And thank you. That's all for the children with cerebral palsy.
Hello, good day, everyone. I am J. Mark B. Rubilius, and together with me is Christine Ara Mercado. And today we are going to talk about a health condition, which is the glucose 6 phosphate dehydrogenase deficiency or G6PD deficiency. So, glucose 6 phosphate dehydrogenase deficiency is the most common enzyme disorder in humans, affecting over 400 million people worldwide. Notably, it is especially prevalent in malaria endemic regions such as parts of Africa, where the deficiency provides partial resistance to Plasmodium falciparum, this is the parasite responsible for the most severe form of malaria. Specifically, it is a genetic condition in which the body lacks enough G6PD enzyme, making red blood cells vulnerable to oxidative damage. As a result, without sufficient levels of this enzyme, Red blood cells are more prone to destruction when exposed to specific triggers, such as certain foods, infections, or medication. Consequently, this premature breakdown of red blood cells, known as hemolysis, can lead to anemia, which may present with symptoms like fatigue and pallor. Moreover, the buildup of waste from destroyed red blood cells can result in jaundice, marked by yellowing of the skin and eyes, particularly in children. And since the gene is located on the X chromosome, the disorder is more common in males. But why? This is because males having only one X chromosome inherited from their mother will develop the disorder if that chromosome carries a defective gene. In contrast, females inherit two X chromosomes, one from each parent, and are less likely to be affected unless both carry the mutation. As a result, many female carriers remain asymptomatic but can still pass the gene to their offspring. Importantly, G6PD deficiency is not contagious and cannot be transmitted from person to person. G6PD deficiency is manageable with proper care and avoidance of triggers. Therefore, management often involves a team of healthcare professionals to ensure safe and effective treatment, particularly in severe cases that may require transfusions or supportive care. And the need for regular medication reviews by healthcare providers are essential to avoid drugs that can cause hemolysis. And next is that we will going to talk about its pathophysiology. To begin with, G6PD deficiency starts with a decrease in activity of the G6PD enzyme, which is important in the hexose monophosphate pathway. This pathway is the only source of non-pH in red blood cells which don't have mitochondria, or your non-pH is known as in long term as nicotinamide adenine dinucleotide phosphate. So that is why, as a result of this decreased G6PD activity, the production of your NOD-pH is also reduced. NOD-pH is essential for keeping the antioxidant glutathione in its active form. Following this, there is a reduction in glutathione levels, and without enough glutathione, red blood cells lose their main defense against reactive oxygen species, or your ROS, which are harmful byproducts of normal metabolism and environmental triggers. That is why ROS begin to accumulate. This oxidative stress becomes even worse when exposed to triggers like infections, certain drugs, and faba beans, which all increase the production of your ROS. Because of the high levels of our ROS, hemoglobin inside red blood cells gets damaged, and this leads to the formation of Hens bodies, which are clumps of denatured hemoglobin. In response to this, the spleen attempts to remove the Hens bodies, and during the process, parts of the red cell membrane are taken out as well, producing abnormally shaped cells called white cells. At the same time, the cell membrane themselves becomes more fragile and less flexible due to the ongoing oxidative damage. And as the damage continues, this leads to hemolysis or the destruction of your red blood cells. Hemolysis may occur inside the blood vessels, intravascular, or in the spleen and liver extravascular. This destruction causes several clinical effects. First is the release of hemoglobin in the blood can result in hemoglobinuria or dark colored urine. Patients may also feel weakness due to the loss of oxygen carrying cells. In addition to that, the breakdown of hemoglobin increases bilirubin levels, which can lead to jaundice or yellowing of the skin and eyes. And to compensate for this loss, the bone marrow responds by releasing more immature red blood cells called reticulocytes. These younger cells have higher G6PD activity and help in temporarily restoring red cell levels. This is why the condition usually resolves within 4 to 7 days. However, in some cases, especially with ongoing triggers or genetic variants, the condition may lead to chronic non-spherocytic hemolytic anemia or CNHA, because if left untreated, this could result in serious complications like kidney failure. That is why, in conclusion, G6PD deficiency follows a clear path from enzyme deficiency to oxidative stress and ultimately red blood cell destruction. Recognizing and avoiding the triggers is key to preventing severe outcomes, helping patients recover.
For the common tools used to assess the nutritional status of children with G6PD. For the anthropometric measurement, heights are measured with the child standing barefoot and upright against a wall or using a stadiometer, while weights are obtained using calibrated digital scales. For the body mass index, it is calculated using the formula weight over height, and children are classified as stunted, wasted, or underweight if their height for age Z scores, weight for age Z scores, or BMI for age Z scores fall below -2 standard deviations from the reference population mean. For the biochemical measurements, plasma zinc concentration it is a critical biochemical marker for assessing nutritional status of children. It is measured using graphite furnace atomic absorption spectrophometry with deficiency defined as levels below 60 microgram per liter or 60 or zero point 0.6 microgram per ml for children aged 0 to 10 years old. Ferritin serves as the primary indicator of iron storage, with levels below 12 to 15 micrograms per liter in diagnostic of deficiency. While retinol binding protein or RBP, a surrogate marker for vitamin A status, it is observed in up to 30.9% of children with hematologic conditions, with levels below zero point 0.7 micromole per liter, indicating vitamin A deficiency. For the dietary measurements, the 24-hour food recall, this method helps evaluate whether the child is receiving adequate calories, iron, folate, and vitamin B12 while identifying potential triggers such as faba beans, which can provoke hemolytic anemia in G6PD deficiency individuals. The Food Frequency Questionnaire or FFQ, this tool is particularly useful for identifying regular consumption of high-risk foods like legumes or items containing certain dyes or preservatives that may exacerbate symptoms. The food diary provides a detailed record of all foods and beverage consumed over several days, offering insights into eating patterns, nutrient gaps, and potential dietary triggers. For the specific biochemical test for G6PD, for the laboratory studies, um, first is the complete blood count or CBC. It is used to assess the red blood cells levels. Next is the bilirubin level. It is it is used to evaluate blood cell breakdown. Next is the reticulocyte count. It is used to measure new red blood cell production, and the serum aminotransferase. It screens for liver involvement, and then the lactate dehydrogenase or the LDH. It detects hemolysis. And next is the G6PD enzyme activity test. It This test confirms the deficiency of G6PD individuals. And lastly, the peripheral blood smear. It identifies abnormal cells like sky, schistocytes and Heinz bodies indicating hemolysis. For the specific dietary requirements for children with G6PD, individuals with glucose 6-phosphate dehydrogenase deficiency can generally follow a regular, healthy diet intake like those without the condition. If they avoid, if only if they avoid specific triggers like faba beans. The most notable dietary concern is faba beans, which may cause hemolytic anemia in some individuals with the condition. While no single nutrient or supplement has been proven to treat G6PD deficiency directly. Certain nutrients may support antioxidant defenses and overall red blood cell health, such vitamin E, vitamin C, selenium, and L-cysteine. For the nutrients that can support Antioxidant is the vitamin E. It serves as a powerful antioxidant that protects the red blood cells from oxidative stress. Also, vitamin C can help reduce oxidative stress and support immune function, but should be used consciously in high doses as it may act as pro-oxidant. And next is the selenium. It works with vitamin E to protect cells from oxidative stress. And now, lastly, the L-cysteine, a precursor to glutathione, the body's major antioxidant. It helps boost the glutathione levels of G6PD deficient cells. Although these nutrients can be beneficial for general health, the best nutritional approach remains a well-balanced diet rich in antioxidants and essential vitamins and minerals.